Hello, this is Dr. Hausinger at St. Martin's University, and this is going to be Chapter 5 from the Van Wormer textbook, Gambling, Eating Disorder, Shopping, and Other Behavioral Addictions. All right. So your text starts out by discussing that, and I quote from page 190, addiction occurs within a web of socioeconomic, biological, and psychological influences. So we're going to be looking at behavioral addictions and problem behaviors that are mostly legal until maybe taken to an illegal extreme. And some of them are a little difficult to avoid, such as, eating and shopping for things that you might need versus want. So behavioral addictions kind of been kept separate from other addictions. However, the brain research shows us that there are a lot of similarities in terms of where the addiction occurs in the brain. Okay. And these addictions and behaviors involve everyday activities. Okay. Right. Just like substance addictions, we might be able to explain behavioral addictions by lower levels of dopamine receptors in the brain. And so we might have activities that are designed to fill a gap, or maybe somebody becomes addicted to an adrenaline high, adrenaline junkie, extreme sport, or they've had a trauma, or there was a relationship, or any combination of those factors. We're going to start off by looking at gambling. So gambling has become socially acceptable and a lot more available than in the past, largely due to the internet. So we have the criteria of pathological gambling that looks pretty similar to the criteria for alcoholism. Preoccupation, increasing amounts, behaviors that have impacted relationships. So it's very, very similar to the criteria for for substance disorders. And about 3 to 7% of gamblers have problems, and suicide is highest in gamblers as opposed to substance use. So substance use has about a 20.9% of suicide rate, whereas gambling has a 37.2%, which is quite startling. So when we look at the cost of the economy, we're looking at accumulative numbers such as bankruptcies, lost work time, crime, and a lot of gambling crime has to do with white-collar crime, so embezzling, fraud, etc., to get money and to gamble in large amounts. Okay. There are cultural and gender differences with gambling. So Native Americans overall have the highest rate of gambling, whereas those who identify as white and black have lower amounts of gambling. However, those in the black demographic that do gamble are more likely to have problem gambling behaviors, and that's true with the Asian population, which also has a very low rate of gambling. However, those that do gamble are more likely to have a problem with it. Okay. Countries with gambling casinos have higher crime rates and bankruptcies than others, so that would make sense. Okay. All right. So a lot of the problems with gambling occur among the elderly, and there can be biopsychosocial reasons for this: isolationism, boredom, and also having perhaps a steady income paycheck that comes in. Anecdotally, you will hear that there are more people coming in on the first of the month, first of the 10th when checks come in. Okay. All right. Now, it would make sense that internet gambling is very fast. It was interesting to look at how the NFL actually was more in favor of that with fantasy football leagues and things of that nature. Okay. Now, women and men have different reasons that they gamble, and women are more likely statistically to call a self-help line, but there are proportionately more male gamblers. However, gambling treatment is few and far between. There is an increase in co-occurring treatment, specifically for and substance use and gambling. And we see these things go together as well. It's really not uncommon for somebody that has a gambling problem to have a substance abuse problem and vice versa. And you also see this with methamphetamine, because if somebody's has a gambling addiction and if they use methamphetamine, then they can gamble a lot longer and maybe stay up for 12 to 24 hours, as opposed to somebody that is not under the influence of a very powerful stimulant. Okay. So the interesting thing with gender too is that both groups prefer the electronic games, and electronic gambling really revolutionized this, that it's a lot faster than the old slots. You can do more pulls on the handle, or more rounds than you could on a manual slot machine. Okay. So women tend to gamble to escape, as some of the accounts in your books talk about that. It's like a vacation for the brain. And men are more driven by the action and the thrill. Okay. And gambling is associated with other problems as well. So we see more disordered gambling and internet addiction for those that are male, have a higher education, higher socioeconomic status, more tech savvy, and higher rates of substance use. However, in the United States, it's estimated that there's 5.7 million disordered gamblers. We see gambling among people that are more likely to be vulnerable and at risk for other things as well. So there's a high rates of gambling for people that are homeless, okay? And minorities. Okay. All right. Okay. So the questions for screening for gambling are pretty similar to those for alcohol. They're almost identical. We just substitute the words gambling and money with substances. So have you ever borrowed money in order to gamble it or cover lost money? Have you ever thought you might have a gambling problem, or somebody told you that you might have? Have you ever been untruthful about the extent of your gambling or hidden it from others? Have you ever tried to stop or cut back on how much or how often you gamble? So those are very similar to the substance screening questions that we looked at earlier this semester. Okay, so one of the themes for this chapter, and if you've read the whole chapter, the treatment modalities are similar in that motivational therapy and cognitive work seem to have a high efficacy for behavioral disorders as well. Okay. There's a lot of irrational thinking, all or nothing thinking surrounding all of these different disorders. Now, it's very disproportionate here that $36 million is spent on treatment, as opposed to the $20 billion in tax revenues from gambling. So in the past, there's been lobbying to support legislation saying that a specific amount of proceeds needs to go to treatment, but as you can see, we're just a fraction here. Right. So with the irrational thinking, and we see this at sports games, and we just had the Super Bowl, people doing things like not washing their socks or their jerseys, thinking that it's going to affect the team. So very unrelated, irrational things, or if you make the sign of the cross, or do some other thing with your hand, or spin around in circles 3 times, it's somehow going to affect the machine and cause you to win. Okay, so eating disorders is the next section of the chapter, okay? Starting on page 212. And there certainly are gender differences here, maybe even more so than any of the other addictions that we look at. So oftentimes we do see a correlation between people with eating disorders and other disorders as well. Just like I mentioned earlier with gambling and certain drugs. There are drugs that are appetite suppressants, such as methamphetamine and cocaine, and so it's not uncommon for somebody to use a substance to feel satiated. Okay. So 90% of anorexia and bulimia are found in females. However, there is evidence to support that there's a rising number of males that are having that too, and that's correlated with body and muscle dysmorphia, specifically for male athletes in areas where they might have to make a weight class, such as wrestling or bodybuilding as well. Okay. So in general, eating disorders do begin in adolescence. However, there is a rising number of women after 50 that are developing eating disorders. Okay. So we have quite a stark contrast here. 0.5% of girls and women are anorexic as opposed to 1.3% that are bulimic. And anorexia is certainly easier to detect, especially visibly, whereas bulimia is not as easier to detect because a person maintains a healthier BMI, or they might even appear to be a little bit overweight. However, it does a lot of internal damage. So your book defines anorexia as a refusal to maintain a minimally normal body weight and fine body hair. Okay. So this is something that is clinically measured by weight and by body fat. Okay. Has a 10% mortality rate, often by suicide. There is a correlation there with depression, and the body is malnourished, and so it's not getting everything that it needs to run efficiently or healthily. But death also can be caused by starvation and electrolyte imbalance. Okay, it's often correlated with perfectionism, ritualism, high anxiety, low self-esteem, and a family history of depression. Okay. Anorexia is very much related to obsessive-compulsive disorder. There are pro-anorexia and pro-bulimia websites online. And if you were to view them, you would see a lot of these quote-unquote suggestions for cutting weight and rituals and things that people do, counting out, I can only have, 12 grapes and 3 cashews, and measuring everything, counting, very specific with numbers. You have to run 5 miles, not 3.5 miles, or whatever it might be. So there's a lot of rigidity in it, and persons with eating disorders tend to shame themselves. Like, I don't deserve this. I don't deserve to feel good. I'm a fat cow. I should feel this way. I'm going to run 2 more miles because I need to punish myself. So there is very much that negative self-talk, and it's very punitive. So with OCD, we have the 2 main definitions here. Obsessive, so something that's recurrent and persistent thoughts. So a person that's struggling with weight, that might be all that they can think of. Their entire day could be structured around it, down to the minute. And a compulsion would be a ritualistic practice. Okay. So we all hear anecdotes about somebody afraid to leave the house until they move the light switch 52 times, etc. Bulimia, we have an increasing amount of men that are succumbing to bulimia, and gay men are at risk for bulimia for a variety of reasons. However, there seems to be a lot of preconceived ideas and shaming within the gay male community about body and body types, and there's a whole classification system about what people look like and what they're called. Are you an otter? Are you a bear? Are you a chub? Are you a cub? And it can be quite vicious. So we see a lot of bulimia with alcohol misuse. Pretty staggering statistic here, 30 to 70% might have that. They might drink until the point of throwing up, or drink instead of eating to feel satiated. 35% of bulimics experience childhood sexual abuse and use food as a drug. Um, Another statistic that's related to this, 49% of women who have alcoholism in their immediate family are more likely to be obese. Okay, so we could perhaps say that there's a correlation here, as well as those that go on to experiment and succumb to bulimia. To date, there's not a lot of information on compulsive overeating. In the media, you're going to see things like My 600-Pound Life on TLC. The BBC has a show called Super Size versus Super Skinny, where they compare people's eating habits, a person that's severely underweight and a person that's very overweight. And oftentimes, their eating habits are really similar, just the portions are very, 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 very different. So, like the other addictions that we've discussed so far, the theme seems to be that there is a lack of dopamine receptors in the brains of people that have addictions, and that's true too of those that are morbidly obese. Now, after gastric bypass surgery, we see an increase with alcoholism, especially in women. And one statistic that I saw was something astronomical, like 400% more likely to develop alcoholism after having gastric bypass. So there's a couple different things that can contribute to that. One is that to begin with, women do not have a lot of the enzyme that works on alcohol in the stomach, and men do. So when a man imbibes alcohol and it goes to the stomach enzymes immediately start to break that down. Women don't have a lot of that until we get to the small intestine. Okay, so women are more likely to feel intoxicated faster and not need as much alcohol in order to feel that way. And so then with gastric bypass surgery, you are making that stomach even smaller. You're bypassing you're bypassing the normal digestive routes there, and so we're contributing to that even more. Plus, the stomach is no longer as big as it was, and we're changing the absorption there as well. Okay. Now, just like previous studies with addiction that show that through twin studies that genetic predisposition is about 50%. We have that here as well. Okay. And alcohol is sugar, so it would make sense here that a person craving sweets predicted alcohol abuse, and perhaps with the lack of dopamine. So if you go to an AA meeting, what do you have there? You have coffee, you have lots and lots and lots of sugary things like donuts and cakes, and you have cigarettes. As people, recovering alcoholics, they're trying to trip those dopamine receptors and poke those dopamine receptors. It's not going to be as much as it was with alcohol, but it's not a coincidence why alcoholics crave sugar. And one of the things that you can take away from this chapter is that people tend to, not all the time, but many times people tend to trade addictions, or you're more vulnerable, I like the word vulnerable, or predisposed to have another addiction. Okay, so lots of times people are in rehab, they start to feel hungry because they're eating, which is good, and they're worried about becoming fat. Or people, they substituted their food for alcohol, and now they're starting to be nourished again. And then you might have people that start to over-exercise or not eat as well. So a lot of the treatment for eating disorders is co-occurring because such a huge percentage of people with eating disorders do have substance use issues as well. Okay, so intervention is not referring to the television show. Intervention in the clinical or medical term is referring to what treatment technique are we using. So generally speaking, for behavioral addictions, combinations are very, very helpful. And in general, I think holistic treatment, meaning treating all different areas of the brain or body, is very helpful. if we give somebody an antidepressant, well, that's helpful. But if we give somebody an antidepressant and help them with CBT, cognitive behavioral therapy, motivational enhancement or motivational interviewing, and exercise and do lots of different things, then we're going to have a more well-rounded treatment, and you're going to have, I think, stronger results. Okay. So with bulimia, we want to avoid strict dieting because we don't want it to change to the other polarity there, anorexia. And it's not uncommon for that to happen either, for people to have multiple eating disorders over the course of a lifetime. Bulimia, the average length of an eating disorder is 8 years, whereas anorexia could be much shorter. So bulimics tend to have longer stints with that. But that's not to say that it can't switch back and forth, because it can. So because there is that compulsive behavior and often depression, Prozac is effective with anorexia. And the male side of bulimia, which can go with it, of course, is muscle dysmorphia, thinking that they're not big enough. And then we might see people dip their toes into steroid misuse. So antidepressants might be helpful for men with muscle dysmorphia as well. Okay, there's a variety of different treatments. We have our 12-step counterpart, Overeaters Anonymous. For compulsive eating, they follow a 12-step path. Group treatment can be very helpful. So cognitive behavioral therapy is something that's very helpful for anger issues and substance use and eating disorders, and it can show results in as little as 12 sessions. Okay. And CBT can be individual or group treatment as well. Okay. Right. So because our brain is amazing and wonderful and regenerates, we have this theme of neuroplasticity where we can form new connections. So there's been research on positive thinking versus negative thinking and meditation, and you can form new connections and look at things differently and actually shift the landscape of your brain, whereas negative thinking can shift the landscape of your brain as well. Okay, so this brain lock, this all or nothing thinking, that can be corrected. So you think of your brain as a muscle, like any other muscle. We learn new things. Okay. Yes, I know that the brain has a lot of fatty tissue in it, but practicing things helps us with building new synapses and connections. Okay. So there's different treatment programs out there, and you can look at the examples in your book, and people get innovative all the time with different things. Okay, so looking at shopping or spending addiction, which is not currently classified as its own disorder, because there hasn't been enough evidence and there hasn't been enough studies on it to show that it's its own disorder, that it exists on its own. So that's not to say that it doesn't exist. It's just not something that's officially classified right now. So it's in the APA section as needs further study. So we see this in about 2 to 8% of people. Okay. So there's some stories in here about people that have done this for long term. The DSM-5 does list kleptomania. Now, your book also talks about how this can be fueled by different things. Is it thinking that if I have everything, my life is suddenly going to open up because I look a certain way, or is it a keeping up with the Joneses, or is it trying to fill a hole? There is some research that suggests that people who have had a trauma at an early age, or experienced incest or molestation, they might be more likely to have a shopping or spending addiction than those who did not. And we have a Debtors Anonymous group. So similar to, again, the 12 steps. And I think you probably see some crossover between Gambling Anonymous as well, because gambling debts. So, neat. There are some interesting shows on spending or shopping addiction. My Strange Addiction covers it as well. And treatment for this is going to involve a combination of financial counseling, financial literacy, and then, of course, the cognitive behavioral therapy and maybe psychotherapy aspect as well. Cyber addiction, internet addiction, video games, all of these things that are relatively new in our span of time. This is also not currently its own category because there needs to be more research done on it. However, there is an inpatient treatment center in Seattle for internet addiction for juvenile and young adult males right now. And basically, it's unplugged, no screens. They have to go play outside. They have to play, there's basketball, there's sports that they can do. They have to do chores. It's just being unplugged and being analog and learning how to live in that space. Okay. Right. So the book says that right now there isn't a diagnostic criteria for this, but it will look very similar to the other addictions that we have. So are you preoccupied with it? Excessive amounts of time involved in playing. And the book suggests that an average American video gamer in high school might spend 23 hours a week playing video games. Okay. So one of the things that I'm sure you've seen to this point is we're looking at this line. Where is the line between something that I like to do or something that might not necessarily be a negative thing? Where is that line where it becomes an addiction? And although some of these things do not have their own classification, one of the answers to that question is when it jeopardizes your relationships and interferes with your daily living activities. But then that opens up the door for the discussion of what's the difference then between having a really high achieving goal. For example, Olympic athletes are people that are really high competitors, or people with really high pressure jobs, or people that run for office. Are you addicted to that? If you're an Olympic athlete and you follow a very strict diet, you don't really have a lot of time for a social life. You might be training 6 to 8 hours a day. That interferes with your daily living. But is it an addiction? So this is why we have to be very careful about what we classify as addictions. Okay. All right. So the internet, like anything else, has a positive side and a negative side, and it can offer a reprieve or a vacation from life, just like gambling or alcohol or something else can as well. And although we might be seeing more of this in the United States and South Korea, the government has been dealing with it for quite some time. And there are actually detox facilities for people that need to become unplugged from the internet and gaming. Okay. So we are looking at, you'll see in treatment and in social work in general, there's a lot of acronyms. All right. One of the things that you're going to look at throughout these courses and throughout the social sciences is motivation. Okay, so feedback. What's the assessment of the person's use? What are they responding to you? Responsibility. We can be bribed into treatment, of course. And there's this kind of old idea of, hitting rock bottom. And that really has to do with motivation. So if the person has hit a rock bottom, whether or not we agree with that concept, it doesn't matter because it's not the same for every person when they are motivated to make a choice. Okay. Advice, we're going to set goals together. So this is very important that we are collaborative. We don't tell our clients what to do. They are the best experts on themselves. Okay. And that brings us to the menus. Okay. Self-directed change options. Empathy, again, so important, the number one determining factor whether a client perceives treatment to be effective. And self-efficacy, so that goes to, does a person see themselves as being competent? Okay, having a voice, being able to make choices. All right. So harm reduction we can use really for anything. So if a person's trying to cut back on their internet use, they could set a timer, right? A person could get themselves off of mailing lists for things that they want to purchase. Um, if we're used to going to the bar after work, we could just go straight home, no detours, start to exercise that self-discipline. So harm reduction can really be a creative way, creative problem solving, to start reducing the impact of our addictions today. So I encourage you to creatively think about what other things might you suggest to a person that's struggling with a behavioral addiction. Maybe a person runs 10 miles every day, and we're going to say, if you didn't spend 3 to 4 hours a day running, what would you like to do with your time? And the person might say, I might like to volunteer. I might like to play music with my friends. And that would be an example of a measurable goal. Maybe running for 2 hours a day instead of 4 hours a day. Okay, so that's a good example of harm reduction. Okay. Sex addiction is another one that is not currently in the DSM-5, and it's under needs more areas for study. And part of this was a political movement in terms of, who do we say has sex addiction? And it tends to be very high ranking or very famous or very powerful people. And that's an interesting thing to research. Does it go with this type A personality, this risk taker? So it does need more research. However, cognitive behavioral therapy is recommended. The individuals that we see tend to be male. However, anecdotally, counselors and therapists will report that yes, there's a high number of women too, but what that looks like might be different. Okay. All right. Are people, they might be prone to lying. So the example here is President Clinton. But other people disagree that he doesn't fit the profile or the criteria for that. So as you can see, it bears further development. And our 12-step friends, Sex Addicts Anonymous. So that's one of the great things about 12-step is that when there is a need, they're there. If there is something that emerges, that there might not be support in another way, 12-step will come in. Okay. So cognitive therapy is something that is talked about throughout the book. It's not a panacea by any means. However, it's very effective because I like to think of it as a paint by number, or it helps to connect the dots in a person's head, especially where there's distortions. So in motivational interviewing, we're developing discrepancy. That looks kind of familiar to cognitive therapy. We see people with tendencies towards really extreme behavior. And your book gives an example of a person that goes in with a $100 bill to gamble. They lose some of their money and they're like, all or nothing, all or nothing. I'm going to win big, or I'm going to lose all my money. And they don't stop until they lose all of their money, when they could have kind of split the difference. Okay. And you'll see this. I've seen this as an addiction counselor with addiction. People almost become addicted to a recovery lifestyle. And I've heard people say it. I was the best addict there ever was. I did the worst things and I got myself into the worst places, and now I'm going to be the best at recovery. And unfortunately, a lot of those people burn out because it's not balanced. It's not balanced, and that's what we need to strive for. And cognitive behavioral therapy helps us with balance. Okay. All right. And if you need some encouraging, there are a lot of nice 12-step slogans. Easy does it. One day at a time. Nothing changes if nothing changes. But don't use it as lip service. It's important to look at the spirit behind it. It's basically a mantra. Okay. Now, outside of the CBT, there are other forms of therapy. Rational recovery, MET, which is motivational enhancement, which is close to motivational interviewing, but specifically for addictions. REBT is more adversarial. It's related to CBT. but it kind of strips a person's layers down a little bit faster. Hey. If you're interested in looking at different types of therapy, I recommend the Gloria sessions, which was an experiment between Carl Rogers, the founder of person-centered therapy, um, Albert Ellis, who's the founder of REBT, and Fritz Perls, who is the founder of Gestalt therapy. And they all had a session with the same woman. Her name was Gloria, and it was in the early 60s, late 50s. She was a single woman who was recently divorced with 2 children, so it was quite taboo, and she was going through some stigma related to that. And they'd never met her before, and she had an hour session with each of them in their style of therapy. And it was amazing because you could see how she reacted differently to each theoretical orientation. You can find it on YouTube, and I highly recommend it. It's quite fascinating. So I think it's really important that clients know themselves, and it's important that they research different orientations. As if you go to therapy and it's not your cup of tea, you might not want to come back. People have bad experiences. So it's kind of important. Do you want a more adversarial, like, yeah, let's just strip me down and get to the anger because there's truth under the anger, or do you like the empathy? It's different for everybody. So it's important, I think, to have some knowledge of the orientations that are being offered to you. Okay. So with cognitive therapy, we want people to avoid living in the polarities, so black and white thinking. If you are a fan of Carl Jung, that's a polarity, and polarities create a lot of anxiety. And we don't live in black and white, we're in the gray. However, we like to label things, that's Gestalt, and if we don't fit an image, it can cause distress. So a lot of people struggle with this, and so with cognitive behavioral therapy, we break down those ideas and distorted thinking so that we can be more comfortable. Okay. We want to look at things through a strengths-based lens and ask about times when did you handle this problem successfully and what did that look like? Because that might give us a really good point to work off of. Okay. We want to regularly assess for addiction, behavioral, substance. Okay. Assessment isn't just at the beginning of a therapeutic relationship. It happens throughout the therapeutic relationship. Okay. All right. Oops. And a lot of people avoid their feelings in addictions, and so we want to help somebody get back into their body, get back into the breath, and work on how they're feeling instead of just jumping to a compulsion or jumping to a substance. So under treatment in the book, there's a lot of different things that are listed: cognitive behavioral therapy, motivational interviewing, positive self-talk, feeling, anger management, stress management, working on the all or nothing thinking. So as you can see, there are a lot of tools for this, and it's not a one size fits all. We generally want to offer a person a lot of different options and options, and also recommend a couple different things for them to do instead of just one. Okay. So here are some examples, and this is going to look differently if you are lactose intolerant. You probably don't want to drink warm milk. Whatever stress looks like for you. Some people like heavy metal music, like myself, that relieves stress. Other people, that might stress them out. So there's a lot of different things here, and this is an example of how to make something client-centered. Okay. So that was a lot. This chapter is chock full of testimonials and examples and really great information. Please take a look at the materials that are in your Moodle. Thank you for your attention.